Our MEC Minute this month has to do with novel psychoactive substances. Our discussion today is based on an article which was previously posted on Workplace on this subject as published in the British Medical Journal. So why are we going to talk about this? Well, I think we need to do this because these novel psychoactive substances have become present or more present in our community. We have treated patients and will continue to treat patients that have been under the influence of these drugs. And if you think back a year or two ago about bath salts, well, bath salts was one of these novel psychoactive substances, and fortunately it seems to have died out, but I think it may be coming back. And there are other psychoactive drugs out there that we deal with currently, such as some of the fentanyl analogs like afentanyl or the new Acryl Fentanyl, which is starting to make its way into Ohio from the East Coast. So if we look at the categories of novel psychoactive substances, or I'll just call them NPS from this point forward, the first category is the stimulant category, stimulants being similar to amphetamines. And if we look at the stimulant category of NPS drugs, they have either predominantly serotonin effects, which have an effect similar to ecstasy, which is a street drug that we have already been treating, or dopaminergic effects, which have to do with a dopamine effect within the brain. And dopamine effect tends to give patients cocaine-like effects in terms of their response to the drug. The second drug category is cannabinoids or marijuana, and there are marijuana substitutes or synthesized analogs of cannabinoids that are now being sold out on the street. There are also the hallucinogens. For us, the hallucinogens in the past have been either LSD or phencyclidine, also known as PCP, but hallucinogens also include a drug we use in our drug kit, ketamine. Depressant drugs are the fourth category of NPS drugs, and they generally fall into two categories. The benzodiazepine category, we use benzodiazepines on our patients. We carry midazolam in the truck, but there are synthesized or synthetic forms of benzodiazepines that are coming out on the street. Then there are also the opioids that are out there, and for us, the opioids that we deal with are, heroin, fentanyl, afentanyl, soon to be Acryl Fentanyl, and carfentanil. So looking at stimulants, these are typically sold as powders or pills. Bath salts and plant food have been stimulants in the past. They increase the amount of serotonin, dopamine, or norepinephrine within the brain. And depending on which is the predominant substance that's stimulated by these drugs, the patients can have a sense of euphoria or high. These medications are commonly swallowed. Sometimes they're snorted. Sometimes they're administered rectally, or they're injected. These drugs typically, if on the short-term basis, if they're bad or side effects, they can result in agitation or psychosis. Patients, if they become agitated enough, can become hyperthermic. They could have just generalized anxiety, or they can be very vigilant, where any action or word seems to be a trigger to the patient in terms of agitation. If the patient takes enough of the medication, they can have cardiogenic toxicity, so they could have tachycardia. Sometimes, if the symptoms are severe enough, the patients can have a seizure. They could eventually develop respiratory or renal failure if they take the drug long enough or have bad side effects of the medication. And they may develop stroke symptoms or delirium, and they may also develop something called Serotonin Syndrome, which I'll discuss in a minute. On a long-term basis, these patients can have dependence on the medication, they can have persistent psychotic behavior, and they can have impairment of their cognitive function, meaning they may not be able to think as clearly and as effectively as they would normally do if they were not using the drug. Specifically regarding serotonin syndrome, this is something you may encounter in the street with patients who are taking this category of drugs. But you may also see it in some patients who are taking antipsychotics. So patients on antipsychotics are at risk to develop the serotonin syndrome. And these patients are suffering from an excess of serotonin in the brain, and they can develop symptoms that include shivering, sweats, tachycardia, nausea, vomiting, or diarrhea, muscle rigidity, and on extreme cases, seizures. These patients are generally treated supportively. We discontinue the medication that they are taking, whether it's prescribed or whether they're using it illicitly. We'll give them IV fluids to hydrate them, and if necessary, we'll treat them with midazolam to calm them down. There's also a old world antihistamine called periactin, which seems to be effective in treating this problem. What it does is it blocks serotonin in the brain, so it reduces the effect on the patient's body. Moving on to cannabinoids, these are synthetic compounds, cannabinoid compounds. Cannabinoids are what's in marijuana, and these compounds are then sprayed onto herbal mixtures and sold as various compounds that people can buy, and they can smoke or ingest them. We know them as spice. You may have also seen them out there as black mamba or clockwork orange. These cannabinoids tend not to have as many different forms of the cannabinoid substance in them. Some of the chemicals that are in marijuana actually have a calming effect on the patient, and some of these substances in marijuana have a stimulating effect. These pure manufactured versions sometimes have less of a calming effect, so the patient may become agitated, have symptoms of paranoia, psychosis, anxiety. So on a short-term basis, these patients can appear psychotic. They can be confused and agitated. They can be violent. They can be slurring their speech and not thinking clearly. If they have enough of a dose for a long enough period of time, they can develop cardiac toxicity with hypertension and tachycardia, as well as MI, and they may go on to develop renal failure and pulmonary disease and a seizure disorder. On a long-term basis, these patients can become dependent on the medication and develop persistent psychotic illness, and these patients can also develop psychiatric manifestations of withdrawal if they abruptly discontinue this substance after long-term use. Hallucinogens are the third category to talk about, and the hallucinogens are broken down into psychedelics and dissociatives. The psychedelics have an effect similar to LSD, and these patients who take the patients take these drugs tend to have alterations in their experience, kind of like that out-of-mind experience, and some may suffer a stimulant effect, but most do not. The other subcategory of the hallucinogens is the dissociative class. MEC is what's being sold out on the street. In the past, it was phencyclidine that was sold out on the street, and we currently use ketamine in our truck. We use it as a dissociative anesthetic, which means it basically disconnects the brain from the rest of the body, and the patient develops a sense of euphoria. These drugs can be swallowed or ingested nasally. Sometimes they're injected. On a short-term basis, these patients are at risk for injury because they just make bad choices. Their sense of perception is off. And if you look at cause of death for patients using these drugs, the most common cause of death is due to unsafe behavior that puts the patient's health and safety at risk. Sometimes with these patients, they can become aggressive and psychotic. Think about the days when phencyclidine or PCP was more available on the street. Sometimes they can develop cerebellar toxicity, meaning ataxia, trouble with coordination. Sometimes if they take enough, they can suffer cardiovascular toxicity or even respiratory failure. I think we all recognize that if we give ketamine too fast or in too high of a dose, patients may suffer respiratory failure, although it's not common. On a long-term basis, these patients can become addicted to some of these substances. They can have ongoing trouble with mood and memory. They could have abdominal pain, which can be recurrent as long as they're using the drug. And they can also develop renal abnormalities with use of these medications. Generally, not too much of an issue on withdrawal. Finally, we'll talk about depressant NPS drugs, and that category is broken down in two categories that we are well aware of, the first being opioids and the other benzodiazepines. The opioids, for us, the most common thing that we are seeing are the so-called novel forms of fentanyl, which are man-made substances, and they are based upon the fentanyl molecule, but they're adjusted one way or another that can result in better euphoria or longer lasting effects. The drug that seems to be becoming more common in Ohio, based at least on information through the media, is the drug called Acryl Fentanyl, which I'll talk about in a moment. On the benzodiazepine side, these are the Valiums of the world, the Verseds of the world, lorazepam of the world, and there are other versions out there that are manufactured in illicit labs, and those forms of benzodiazepines can have a much longer half-life, and some of them have a half-life as long as 100 hours. So an overdose on these drugs can take a long time to resolve. So the short-term risk of both of these subcategories is overdose with loss of airway. Patients can develop seizures on withdrawal, particularly if they've had benzodiazepines on a long-term basis. Benzodiazepine addicts can suffer withdrawal, and the thing about withdrawal in those patients is that it could be a week or two before they actually have withdrawal symptoms, depending on the half-life of the drug. So a long-term basis is a problem with cognition and addiction, and there could be withdrawal effects after abrupt cessation of either of these subcategories of drugs. Just a brief word about Acryl Fentanyl. I think we've been reading about it in the media and in the EMS or on the EMS blogs. It seems to be a new designer version of fentanyl, and it's moving into the United States. It's probably being manufactured in China and brought to the U.S. Fentanyl and various forms of fentanyl can be bought online and shipped to the U.S. at a pretty low cost, and some of the manufacturers will even replace it if the drug is confiscated by customs once it gets into the States. Acryl fentanyl is known to be more potent than fentanyl. From what I can tell, reviewing the current literature, it's about 1.5 to 2 times more potent. There have been media reports that it's resistant to reversal by naloxone, but published information through toxicology centers and other locations indicate that it is reversible with naloxone, but it takes a greater than usual dose, probably similar to what we've experienced with carfentanil. Looking at the chat boards that are frequented by narcotic abusers, it seems like there's increased interest in acryl fentanyl right now because there's a perception that it gives addicts a better high or better buzz, and that they could get it at a fairly decent price. So that's the end of my conversation on the novel psychoactive substances. Next month we're going to talk about the CARES database and why it's important. The CARES data for those MEC agencies that were members in 2016 recently were released and published, and next month we'll talk about the results and why that's important to the public that we serve.